So thank you very much, Suzanne. I'm happy to bring back Professor Sue Apcon to this time talk about pain in boys and men with Duchenne. I think as parents, we often know that they are hurting and we can't figure out whether that's coming from scoliosis or muscle pain or just really how to figure out where it's coming from and what to do about it. So with that, I'm going to turn this over to Sue and then we'll follow with questions. Ready? It's over to you, Sue.
All right, thanks, Pat. Again, can you hear me and see me okay?
We can.
Wonderful. It's great to be back. I hope everyone enjoyed the break, and I certainly enjoyed the music. It's always fun to be part of an international conference. Again, sadly, we're not in person, but to see the richness or listen to the richness of the music and to see all the wonderful diverse names on the participant list is really just incredible. So thank you for that opportunity. Today, or the second presentation I'm going to be doing today, I'm going to be focusing on the different causes of pain in boys and men with Duchenne, the evaluation process that your healthcare providers may consider, and finally share some approaches to treating the different types of pain. I introduced myself earlier as a rehabilitation physician, and so I typically will focus on the functional limitations, the physical needs of the child or adult. And pain, unfortunately, is part of that. And so I'm going to share much of my experience with you today. This is the official definition of pain. It reads a little bit funny and may translate even more funny, but it is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. What's important to realize is that pain is a very personal experience. You and I will always experience pain differently because of our different biological, psychological, and social factors. What one person experiences as just a little bit of pain, someone else may experience as being severe. Neither is right, neither is wrong. Again, pain is personal. Another important principle of pain is that just because someone can't communicate the nature of their pain, like an infant or a young child, it doesn't mean that they're not having pain. There are common behaviors that I think we all are familiar with, such as an infant grimacing or a child crying, and we just know that that person is in pain, even though they can't tell us about it. There are several types of pain, and it's important to figure out which type someone is experiencing because the treatments may be very different. The first type of pain is nociceptive pain, which is caused by the activation of the pain receptors we have throughout our body. It can be divided into somatic pain and visceral pain. So somatic pain is related to pain in the skin, the soft tissues, muscles, or bone. It's generally pretty easy to localize. An example of somatic pain is the pain felt when someone breaks a bone. Most people would be able to describe this pain as very sharp and be able to point exactly to the location that hurts. Visceral pain, though, is caused by activation of pain receptors in our visceral organs. And visceral organs are organs like the stomach, intestines, heart, and lungs. We talk about those as our soft organs. Visceral pain is much more difficult to describe and can be much more vague. The other big category of pain is neuropathic pain, which is often characterized as burning, shooting, tingling, or even electric feeling. It's related to nerve irritation or nerve injury. An good example of neuropathic pain is when your leg falls asleep after sitting in the same position for a long time. People generally describe tingling or shooting pain in this situation. When assessing pain, these features of pain that I have listed here are important for your care providers to understand when trying to figure out the cause of the pain. Again, in a young child or someone who has difficulty communicating, this can be a challenge. When trying to identify the location of the pain, I generally ask the child with one finger, point to one spot that hurts the most. If there's a broken bone or a skin sore or something like that, it's going to be really easy for that child to identify that location. But if it's visceral pain, like pain felt from a kidney stone, it could be much more challenging for that child or adult to point to that pain. The intensity of pain means how bad that pain is. We often use a scale of 1 to 10, but in a young child, that can be really difficult for them to understand. A better scale for your young child may be the FACES scale, which are pictures of different faces that you can see in the upper right corner. And they help us to describe, they help a child describe the intensity of their pain. So you can ask the child to point to the picture that they feel like at that moment. Determining whether the pain is acute in onset or immediately occurred or has been going on for a longer period of time can be very helpful at knowing what the potential causes are as well as how to treat it. I already talked about the characteristics of the pain, such as whether it's sharp or dull, whether it's burning or tingling. Again, depending on the age of the child, I will often adjust my words. I find asking if it feels like there are bugs crawling all over the skin. If they say yes, it helps me to understand that that child is probably having neuropathic pain versus somatic pain. Understanding what makes the pain better or worse gives me some hints as to the cause of the pain. For example, if a young man who uses a wheelchair full-time tells me that he's having pain in his calf, it gets better when someone massages it, I may think that this is a muscle pain rather than thinking it's related to something like a fracture. However, if the pain is acute, it doesn't improve with massage, hot or cold packs, or acetaminophen, I may think that the cause of the pain is a bigger deal, such as a fracture. And so my evaluation and treatment is going to be different. Finally, I want to understand how the pain is interfering with life. If the pain is making it hard to sleep, hard to concentrate in school, or limiting someone's interactions or interest in going out and playing with their friends, I may do a much more extensive evaluation compared to if it was just minimal pain that came and went and really was more of an annoyance than something that was causing a lot of distress. But let's transition now to talk about the most common types of pain that boys and men with Duchenne might experience. The first and most important point is there really hasn't been any large-scale surveys of pain complaints in Duchenne. The information that I'm going to be sharing is really based on my 20 years plus of experience providing care to boys and men with Duchenne in our clinics at Children's Hospital, Colorado. Preparing for this talk was a reminder, though, that we still have a lot of work to do. Understanding at a much larger level where pain complaints are coming from is something that we really should be pursuing. The list that you see on the left is certainly not a complete list, but more of the common causes of pain. I'll mention some that are acute causes and others that boys or men may experience more chronically. You can see from this list that literally from head to toes, someone might experience pain with headaches starting at the top and the legs at the bottom. We have chest pain, abdominal pain, and back pain that occur somewhere in the middle. As I review the different causes of pain, it's also important to recognize that the causes of pains may vary by the ages of my patients and also the stages of their Duchenne. As a physician, I'm going to be thinking of a very different cause of back pain in an 8-year-old boy than I would in a 28-year-old man. I'm going to take each seriously, but the causes may vary. I'll describe the causes of pain, some of the features of the pain, whether specific tests are needed to be done to diagnose it, and then how I might treat that pain. It's important to remember, though, that I'm not telling you how to treat yourself by providing the general, but I'm just providing that general approach to how I provide care to my patients. And I definitely encourage you to reach out directly to your care providers if you're experiencing pain and how they would best evaluate and treat you. Calf pain and sometimes pain in the forearms or upper arms is very common and occurs across the lifespan. Kids describe it as cramping pain, often occurring in the evenings or at bedtime, more often after an active day. It's common, and it represents the muscle breakdown that we see in Duchenne or Becker muscular dystrophy. On the exam, there's really nothing specific that I'm going to see. In other words, I don't notice any swelling or warmth or redness where the child is complaining about their pain. Sometimes parents will tell me that when they're touching the child's calves, it feels harder than it normally feels. There's not a specific diagnostic test that we do. The treatments can be warm baths before bed, massage, warm packs, and when needed, a dose of acetaminophen can be very helpful, especially before bed. So if a child or parent knows that they'll be awoken in the middle of the night with this type of pain, then I usually will recommend a dose before bedtime. Again, it's usually associated with a particularly active day. If a boy or a man with Duchenne or Becker muscular dystrophy complains of abrupt onset of pain, especially if there's been some trauma, like a fall to the ground, or a leg or arm getting caught when the wheelchair goes through a door frame, you must think about a fracture. It's also important, even when the trauma seems pretty trivial, minimal. We know that people with Duchenne muscular dystrophy have low bone density because of the weak muscles. And those men or boys who are on steroids are going to have an extra low bone density, putting them at greater risk for fractures. Pain associated with a fracture is typically very well localized. In other words, someone can point to the location that hurts. It may be associated with swelling, redness, or even warmth of the limb. Generally, upper limb, in fact, the distal femur, which is the area right above the knee, is the most common location of a fracture. To diagnose a fracture, an X-ray must be obtained with the treatment varying depending on where the fracture is located, how bad it is, and also the ambulatory status of the child. In the setting of a child who's still ambulatory with a femur fracture, we want to advocate for surgery if it's possible to allow for the boy to get back on their feet more quickly than letting the fracture heal on its own. Management of the pain in the setting of a limb fracture is to mobilize the limb, meaning keeping it from moving around. It can be done with a splint or a cast if surgery is not going to be initiated. Medication for the acute management can also be very helpful, and depending on the intensity of that pain, could include acetaminophen, an anti-inflammatory like ibuprofen, or an opioid such as morphine. Now, I'd like to make one comment about the use of an opioid. At least in the United States, there is an epidemic of opioid abuse, which makes doctors and nurses very hesitant to prescribe an opioid. However, very short-term use in the setting of an acute fracture is very appropriate treatment. In a young adult with Duchenne who has respiratory problems, your doctor may be hesitant to use morphine. However, it can be very safely used when used in small doses and with good monitoring. My second comment is about something called fat emboli syndrome, and you may hear about this at another point during this conference. It occurs when a child has a long bone fracture like the femur bone. The fat in the bone marrow can travel through the bloodstream, into the lungs, into the brain, cause significant breathing issues and even confusion. As a caregiver, you may be in the position where you're teaching people in an emergency room setting or a clinic about fat emboli syndrome. So it's important for you to be familiar with it. Back pain in patients with Duchenne can be acute or chronic, and the causes may vary depending on the symptoms. I mentioned that boys on steroids are at greater risk of fractures, and one common place is the vertebrae of the spine. We typically refer to this as compression fractures, and as it sounds, the vertebral bodies compress or collapse on itself, sometimes from trauma such as a fall on the bottom, or sometimes without any significant trauma. Vertebral compression fractures are well localized by pushing on a specific location on the spine. I order an X-ray to confirm the compression fracture. But sometimes that's negative or inconclusive, and that means I might have to order another test like a CT scan to help better identify its presence. The treatment depends on the severity of the compression fractures. In 2018, the CDC guidelines, again mentioned by Elizabeth earlier in the day, can be referenced by your care provider as it has a very clear algorithm to guide the treatments. If it's minor, not causing a lot of pain, something like acetaminophen may be all that's needed. But in the setting of severe pain or severe compression fractures, your care providers, maybe an endocrinologist or an orthopedist, may prescribe something called a bisphosphonate, which can help with the pain and reduce the risk of future compression fractures. Pain in the back can also be pretty vague and hard to describe. It may be intermittent, it could be severe, it could be located more laterally or on the sides of the back. It could be related to a kidney stone, a kidney infection, or even constipation. That's that visceral pain that I described earlier. Your doctors could do a number of diagnostic tests depending on what the symptoms are, but they could include something like a urinalysis or urine culture looking for bacteria, an ultrasound looking for a kidney stone, or even an abdominal x-ray looking for constipation. The treatment will definitely vary depending on the cause of that pain. In the setting of a kidney stone, short-term use of a stronger pain medication may be needed until the person passes the stone. Finally, and very commonly, we see back pain associated with positioning in a wheelchair. We kind of refer to that as myofascial pain or musculoskeletal pain. This is generally not seen in someone who uses a wheelchair just part-time or doesn't use one at all, but for someone who's a full-time user and someone who may have difficulty with repositioning themselves in their wheelchair. Think about sitting in your chair today and watching this presentation or the previous presentations. My guess is that you've adjusted your position multiple times already, maybe leaning forward, crossing your legs, or perhaps like me, a few minutes ago, I stood up to relieve the pressure. In the setting of having limited abilities to do this on your own, a person may experience pain in the back or buttocks. The buttock pain could be described as achiness or even shooting pain down the legs. This is that neuropathic pain that I described earlier. It's from compression of the sciatic nerve. The diagnosis of musculoskeletal pain is generally based on the history and perhaps ruling out other things like compression fractures. If I obtain a history that the pain is better when sitting in a different position, improves with massage or warm packs, then I think it may just be positional. The treatment generally is making sure that that person has the ability to reposition themselves frequently throughout their day, either themselves independently using a tilt or recline feature in a wheelchair, or perhaps requiring someone else, such as a caregiver, to reposition them frequently throughout the day. Finally, in the setting of someone who has a scoliosis or a curve in the spine, close monitoring and consideration of spine surgery may be needed to assure that the most upright position in a wheelchair is obtained, because a scoliosis can lead to an awkward sitting position and therefore pain in the back. Medications that can be used intermittently, such as acetaminophen or an anti-inflammatory, can be very helpful. I've also had success with warm packs and even something called lidocaine patches. Lidocaine is a good pain reliever. It's embedded in a patch, and that patch can be put over the location, such as the back, for good pain relief. I want to make one comment here about the use of anti-inflammatories, such as ibuprofen or ketoprofen. Our cardiologists usually recommend avoiding them if the patient is on an ACE inhibitor or something like lisinopril or enalapril, because both can affect the kidneys. Occasional use may be okay, but consistent use should definitely be avoided. And I encourage you to talk with your care providers about what medication would be right for you. I already mentioned that constipation is a possible cause of back pain, but abdominal pain is a much more common complaint. Constipation is described as infrequent stools. When the stools are finally passed, they're quite hard or very large. Diagnosis can be based on the history, but in the setting of pain, I may get an abdominal x-ray to look for large volumes of stool that hasn't yet been passed. It helps me to develop a treatment plan that could include increasing water, modifying the diet, or even using a laxative, suppository, or an enema for a good bowel cleanout. Steroids can also thin the lining of the intestine and lead to an ulcer. While it's rare cause of abdominal pain, you should be aware of it, and it's oftentimes associated with a burning sensation, vomiting blood, or passing very dark, almost tarry looking stools. Reflux, also known as heartburn, is another cause of abdominal pain, and oftentimes that location is a little bit higher up, even close to the chest or even the throat. There may be a very funny or sour smelling breath of someone who refluxes. While there are x-ray tests that can be ordered, I oftentimes will just prescribe an over-the-counter medication, such as an acid blocker, to see if that helps, and order subsequent testing if needed. And finally, in someone who's older, who has significant muscle weakness, or as their muscle weakness progresses, they can develop a delay in emptying food from the stomach. It's referred to as gastroparesis. Symptoms can include abdominal pain, pain after eating, feeling full quite early in the meal, or nausea, or just even a decrease in desire to eat altogether. There are special x-ray tests that can be ordered to help diagnose this, and the treatment may include modifying the diet, eating smaller meals, trials of medication, and if severe, even a feeding tube that bypasses the stomach altogether. I'm not a cardiologist, but chest pain is certainly something that boys and men with Duchenne and Becker experience. I'm not going to talk today about the heart causes of chest pain, but of course, if someone is having chest pain, then really thinking about cardiac causes first and contacting your cardiologist or primary care provider is going to be important. I've listed, however, other causes of chest pain like reflux, which we talked about earlier. If someone has had trauma to the chest, or there's pain when pushing on a specific location, it's much less likely cardiac in nature. It can be related to a muscle strain or rib fracture. The treatment in that case is going to be pain medications or icing over the area, or even that lidocaine patch that I talked about earlier. Complaints of chest pain can also be caused by a pneumonia. In that case, those symptoms are going to be difficulty with breathing or shortness of breath. To diagnose a pneumonia, you're going to obtain a chest x-ray, and again, treatment is going to be specific to that cause. The most important point on this slide is to remember that not all chest pain is caused by a problem with the heart. In fact, especially in young children, most chest pain that I see in my clinic is not related to the pain, is not related to the heart at all. I mentioned earlier that there's a type of pain that we refer to as neuropathic pain, meaning pain coming from an injury or pressure on the nerve. The sciatic nerve originates from the low back and runs down the back of the thigh, so we get irritated when sitting too long. The femoral nerve runs along the front side of the thigh, so when someone is positioned very forward and leaning on their thigh, they experience neuropathic pain, or shooting or burning on the top part of the thigh, oftentimes on the lateral or outside aspect of it. This type of pain, again, is described as burning, tingling, or even numbness. And I base my diagnosis of this type of neuropathic pain on the history. And the good thing about this pain, the treatment is simple in terms of just repositioning, removing that pressure. I will typically remove that neuropathic pain. If the pain is chronic, however, and not relieved by repositioning, then I might order a CT scan or an MRI of the spine to make sure there's no compression of the nerves that are coming out of the spinal cord. While this is possible, it's pretty rare that we see this. Tingling in the arm, especially down the pinky or small finger side of the hand, is usually related to pressure of the ulnar nerve at the elbow. It's usually related to resting the arms on a table for too long, or an armrest that's improperly positioned. If you have ever hit your elbow and experienced that shooting sensation down the side of your arm to your fourth and fifth fingers, you'll know what that pain feels like. We refer to this, in at least our country, as hitting our funny bone, but most people would say that it's not really funny because it does hurt. The treatment of an ulnar nerve pain is to look at the positioning of the arm on the armrest, to make sure that you maximize the pressure, you minimize the pressure over the elbow and kind of maximize it over the entire forearm. I also typically will recommend getting more padding added to the armrest if that is the situation. Finally, it's important to remember that just because a child or adult has Duchenne muscular dystrophy doesn't mean that they can't develop pain related to very common conditions seen in all children and adults. Having Duchenne does not protect someone from getting an ear infection, a pharyngitis or a throat infection, or even developing appendicitis. As you're having your son evaluated, or you yourself are getting evaluated for acute or chronic pain, it's important to tell your care providers about the diagnosis of Duchenne, what medications you're taking as part of the Duchenne treatment, but ultimately the cause of the pain may be unrelated to the Duchenne and just related to being a typical child or typical adult. I'm going to make a funny transition here. Elizabeth had asked me to spend a few minutes on the topic of cannabis use or marijuana, weed, pot, however you refer to it in your country, and how some people may use it for pain relief in the setting of Duchenne or Becker muscular dystrophy. I'll start by saying that we have a lot to learn about how people with Duchenne use cannabis. In other words, why they use it and the effects that they receive from it, good or not so good. In the United States, many of the states have passed laws that have legalized the use for medicinal reasons and others for recreational and medicinal reasons. I know that in Europe, it's been legal for a lot longer than it has been here in the United States. So perhaps some of you on this call will have more experience or more information to share later. For those of you who aren't familiar with cannabis, it's a general term for products from the cannabis sativa plant with two major components of it, the THC, which gives you that high or pleasurable feeling, and the CBD, or cannabinoids, which have other properties that people use to reduce anxiety, maybe help with sleep, or reduce pain. Our bodies have receptors that respond to the CBD that our body produces on its own. Those are called endogenous cannabinoids, or those that we smoke or ingest in other ways. Because there's really not a lot of any literature, to the best of my knowledge, on the use of cannabis in people with Duchenne, I set out to better understand it through a national survey sent to families who have sons with Duchenne or Becker muscular dystrophy over 18 years of age. Thanks to Parent Project Muscular Dystrophy to helping support this work. Because I've not yet published this data, I'm going to share just a couple of general findings with you. We received surveys from a total of 250 people, with 15% of them completed by men with either Duchenne or Becker over 18 years of age. 25% of the respondents had ever used used cannabis products. Of the current adult users, the average age was in the early 20s, I think about 23, and more had Becker than Duchenne muscular dystrophy. Most were using it like a medicine, meaning they were using it on a scheduled basis. 2/3 of them were using a product that had a combination of CBD and THC. Smoking and taking edibles were the most common way that people consume cannabis. Approximately 70% of respondents said it helped moderately or a lot their anxiety. 84% said it helped moderately or a lot their muscle cramping. And 76% of them thought cannabis helped their pain moderately or a lot. For those using, side effects included, but weren't limited to, moderate anxiety in 25% and moderate decrease in attention in another 25%. These are just a few examples of what we are learning about those who use. And I'll share more as we're able to analyze that data and publish it, hopefully later this year. When I talk to families who ask about cannabis, I generally share a few thoughts about that. First, at least in the United States, the products are not regulated, meaning that there's a different concentration of THC and CBD, making someone's response very inconsistent. The same product used on one day could look very different than the experience you're having on a different day if using a slightly different product. I share that people with respiratory issues, such as someone with Duchenne, should not be smoking or vaping anything, especially cannabis, because of the higher risk of lung injury. And finally, cannabis use in those under 16 years of age has been associated with decreased verbal IQ, attention, memory, and executive function. Those are typically developing young adults, so kids without Duchenne. My take-home message is that we still have a lot to learn about cannabis use in boys and men with Duchenne. And while there may be some perceived benefits that we're learning about from those who are using, it's unclear whether or not there's some negative impact that they could be experiencing that we haven't yet identified. So I'd like to spend the next few minutes or two just summarizing what we know about pain in boys and men with Duchenne. Many of the causes of pain are related to the underlying condition or treatment that we prescribe, and they include calf pain, higher risk for fractures, and subsequent pain related to them. It's also important to remember that causes of pain can be the same causes seen in people with Duchenne muscular dystrophy, like appendicitis or an ear infection. Your care provider will diagnose the causes of pain based on whether it's acute or chronic, where the pain is located, the intensity, the characteristics of the pain, and other factors that we discussed today. And finally, there are a lot of good treatments for pain, and those treatments recommended will depend on what the cause of the pain is and may include medications, including acetaminophen or an anti-inflammatory, or even something like morphine, but also other options such as massage, warm packs, or even repositioning in a wheelchair in the setting of musculoskeletal pain or neuropathic pain can be very effective. With that, I will end my presentation and I'm happy to take questions.
Thank you, Sue. That was really a terrific presentation. We also appreciated